So, our discussion of the spinal cord has led us to plexuses. And there are 4 major plexuses in the spinal cord, 4 major ones. We're talking about 1 in depth. We're not even really going to mention 1, and then 2 we'll just gloss over, give them a brief overview. And actually, the cervical plexus is one that I didn't want to mention at all, but I just felt bad not mentioning it. So I'm going to put 3 points up, only 3 points. I'll put them all up so you can scramble and copy them down. The only thing that I want you to know about the cervical plexus is that a few candidate nerves that we're going to revisit arise here. So I don't want you to be surprised when you see the names of some of these nerves later. So I'll just put all the points up. And I'll say briefly that the cervical plexus really innervates the top of the shoulders, top of the chest, face and neck, things that the cranial nerves don't innervate. Areas that the cranial nerves don't innervate. There's a little bit of overlap, but not a lot. Key nerves of interest, the phrenic nerve. The phrenic nerve arrives here, and the job of the phrenic nerve is to control the diaphragm. One of the, if not the, major muscle involved in respiration. You activate the phrenic nerve regularly. So an important nerve that we'll come back to, and we'll also see the supraclavicular nerve, which sounds like a mouthful, but I think you're starting to realize, and I'm going to reaffirm this as we go through the material, that a lot of the names indicate actions, origins, insertions, the terminals. Supraclavicular nerve simply means above the clavicle. And then when we look at that nerve, you'll see why it's named as such. There are a few things today that we'll discuss where the name is a giveaway. And then a few things where it's a bit of a distraction. So I want you to see these before we keep going. We're not going to see them today, we'll see them later. They arise in the cervical plexus. And that's interesting. If you think about the phrenic nerve going to the diaphragm, which is down here, why would it arise in the cervical plexus? What we will spend a fair bit of time discussing is the brachial plexus. The brachial plexus. The second of the 4 plexuses that arise from the spinal cord. And it supplies almost the entirety of the upper limbs. The brachial plexus provides motor activation and receives sensory information from almost the entirety of the upper limbs and the shoulders. I like to think about this every time I dislocate my shoulders and how it's getting compressed and causing all the nerves and muscles, or the nerves in my arm, to fire like they've never fired before. Very complex mesh of nerves that arise from C5 through C8 and T1. And you'll remember last class, or even, it was last class, last Thursday, we mentioned that the roots of the spinal nerves are named for where they arise in relation to the vertebrae. And the vertebrae aren't our focus of study, but I think it's worth bringing them up here. You can see them on the right-hand side. There are 7 cervical vertebrae, 12 thoracic, 5 lumbar, etc. What we care about is where the nerves arise. And this is also an interesting point because this is where the naming switches. The cervical vertebrae and the cervical nerves are named for the vertebrae just below them. So C5 nerves, or roots, arise just superior to the C5 vertebrae. And so do C6, and so do C7, but there's no C8. There's no C8. This is one exception to that rule. We name these cervical 8 roots, but they arise superior to the thoracic vertebrae number 1. From this point onwards, that is reversed. Above, in the cervical regions, the nerves are named for the bone immediately inferior or below them. From the thorax down, they're named for the vertebrae immediately superior or above them. So T1 arises below T1, and this carries on for the rest of the spinal cord. So C5, C6, C7, C8, and T1 are the roots of the brachial plexus. They all arise above the first rib, and they're posterior to the clavicle. So to give you an idea of where we are, clavicle, posterior to that, behind it, above the first rib. And you can really, if you try, you can kind of feel your first rib, but it's down there. So deep to the neck, that's where we're looking. There's an organization to the brachial plexus, and you can see the mnemonic in the bottom left. Roots, trunks, divisions, cord, branches. Risk takers don't cautiously behave. That is the order for spinal roots. They are the spinal nerves. The roots of the brachial plexus are the spinal nerves. They are C5, C6, C7, C8, T1. They are the spinal nerves. They arise right off the spine and immediately merge. Immediately merge into trunks. 3 main trunks just at the base of the neck. Superior, medial, and inferior trunks. Just at the base of the neck, deep to the clavicle. Behind the clavicle, those divide into divisions. A repartitioning of sensory information from the trunks to the rest of the body, just behind the clavicle. So we're moving down. The clavicle then combines into cords in the armpit, in the axilla. You can reach these from underneath. Lateral, posterior, and medial cords aren't immediately obvious like the superior and inferior trunks, but they're named for their relationship to the axillary artery. This is just a trace of all the nerves. There's also blood supply and blood drainage that travels with these nerves. The axillary artery is in the middle of these 3 cords. It's below or medial to the lateral cord, in front of the posterior cord, and then lateral to the medial cord. So they're all named for their relationship with the axillary artery. That's coming up. That's not a major focus now. And then finally, the branches are the terminal nerves that we recognize in the limb. There's a lot of them listed here, but the important ones are as follows. The axillary nerve, we'll talk about all of these today. Axial nerve, a small branch off the posterior cord. Axillary nerve sounds like it goes towards the axilla and stays in that region, and it does. The musculocutaneous nerve, which is not an immediate description of what it does, but I'll show you that on the next slide. The musculocutaneous nerve. The radial nerve and the median nerve. The median nerve and the ulnar nerve are the 5 main terminal branches of the brachial plexus. We'll see these show up as we talk about the axial skeleton and the upper limbs, which is not too far off. It's important to know where they arise so you can understand how they travel and what they do when they reach their destination. We'll do a brief overview today. So axillary, musculocutaneous, radial, median, ulnar. I also want to point out an odd nerve. We will talk about this later on today, but there's one odd nerve that doesn't go through the convergence, division, and branching of the brachial plexus, yet it is part of the brachial plexus. Exceptions are always the easy ones to remember, right? That's the long thoracic nerve. The long thoracic nerve arises directly from the roots. It doesn't arise from a trunk or a branch or a cord, directly from the roots of the spinal column. And its job isn't important yet, but we'll see that in 2 or 3 slides. So because we're coming back to it, I thought I'd point it out to you here so you can see what it looks like. It's obvious. If you were to look at a real dissection, you could notice this nerve obviously because it arises directly from the roots and not from the brachial plexus itself. So the brachial plexus is the gateway to the upper limb. The upper limb shown here. Some bones to anchor you in space, no other major features. You can see the shape of the body, but muscles aren't really a concern yet. What I'd like to do on this slide is show you where those major nerves go. So they're important. We'll take a look at them here. Axillary nerve. The nerve that innervates the deltoid muscles in the region of the axilla. Deltoid muscles, there's also some rotator cuff muscles that it innervates and anchors the deltoid to the scapula. Deltoid, the humerus to the scapula. Deltoid, one of the major muscles that does that. The names of those muscles aren't necessarily important now, but you've heard of them, and I think it's important to prime your understanding for when we get to that section. So a small branch of the posterior cord that innervates the deltoid muscles. And you can see the tree-shaped network underneath this red T that I added to highlight where it is for you, but there's this dispersion in the area of the shoulder muscles. That's the axillary nerve. Musculocutaneous nerve. Anterior arm muscles. You can see it highlighted here. And when I say anterior arm, I typically mean upper arm. Same with leg. I mean upper leg or thigh. If I mean the distal portion, I'll say forearm or lower leg. So anterior arm muscles. It's a small branch off the lateral cord. Both of these are small branches so far and not obviously notable or major parts of the brachial plexus. They are small offshoots. The axillary from the posterior and musculocutaneous from the lateral cord. Radial nerve is fairly long. It's a nice big one. And it is the manifestation of the posterior cord. The posterior cord is the radial nerve. And you can see it traced out here, although the highlight goes across the front surface of the humerus. The nerve travels behind and innervates the posterior arm muscles. Radial nerve is the posterior cord. Posterior arm muscles, posterior cord. Median nerve, fairly long nerve, goes all the way to the hand, has some innervation of the hand, but its major focus are the anterior arm and forearm muscles. Median nerve is a large nerve, anterior arm and forearm muscles. The median nerve is a combination of the medial and lateral cords. They combine to form this, the median nerve. The lateral and the medial cords combine to form the median nerve. And finally, I'll show you the ulnar nerve. I always remember ulnar because in the anatomical position, it's on the border of the arm that goes into the armpit, the medial surface. The inferior part of the brachial plexus, the medial part of the brachial plexus. And wouldn't you know it, it is the descending form of the medial cord. The ulnar nerve is the medial cord, after some nerves branch off to form the median nerve. The ulnar nerve is the medial cord. It largely innervates the hand, sensations in the hand and motor control of the hand, fine dexterity motions, but also some forearm muscles. We call it anteromedial because it's the front, but also the medial surface. Mostly sensation from those areas. And the medial 1.5 digits of the hand. So if you ever stretched your arm too much or leaned on your hand a lot, the ulnar nerve wraps around the elbow here, and you can stretch it, and the fingers, these two medial fingers on your hand start to go numb. Only these ones. It's the ulnar nerve. I always get that because I think it's messed up from dislocating my shoulders, but always these two fingers, and only these two. Superficial innervation by the ulnar nerve. So if everything works normally, the arm works as intended. You feel sensations, you activate muscles, you can supinate and pronate. Know the difference between supinate and pronate, by the way? So this is the action that I'm describing. Which way is supinate? Palm up, holding a bowl of soup. Pronate's the other one. Yeah, good. So given what we know about our brief foray into the brachial plexus, there are some obvious discrepancies, things that can happen if there's ever damage to the brachial plexus as a whole or parts of the brachial plexus. And those are shown here. And it's not something that necessarily requires memorization to understand, but just if you know the areas of the arm that these nerves innervate and the actions that are reflective of the damage, it's not hard to discern what parts of the brachial plexus are damaged. The Erb-Duchenne palsy is a little bit more complex. There's a lot of nerves that are involved in it. This is the kind of injury that happens from quick abduction of the head away from the shoulder. Quick abduction of the head away from the shoulder. That action would be a quick departure or separating of the head from the shoulder. So, football tackle. Or sliding into the boards playing hockey if you lose your skate. Something like that forces your shoulder down and your head away. Common during childbirth too, if there's too much pressure or pulling on the limbs and or the head or separating of the head from the shoulder. So overall, the areas that are susceptible here are the upper borders, the lateral aspect of the brachial plexus. The axillary nerve, the musculocutaneous nerve, so the deltoid muscles aren't active. There's a rolling of the shoulder forward. The lateral arm is damaged, and the anterior muscles of the arm are damaged. So we have this waiter's tip looking for a tip posture as the fellow reaches behind him. So mostly damage in this region, the superior or the lateral border, depending on how you look at it, pulling the head away from the shoulder, stretching the trunks and spinal roots in that area. Wrist drop is second. It's different. It's exclusively related to damage in the radial nerve. The radial nerve. So the posterior forearm muscles innervated by the radial nerve. We saw it on the last slide. Radial nerve is damaged. The posterior muscles don't work as well, which act to dorsiflex or extend the wrist. The anterior muscles try to lift the hand, which are damaged, can't work, therefore wrist drop, the colloquial name for damage to the radial nerve. Inability to extend the wrist, all the posterior forearm muscles have lost function. Because of where the radial nerve is in relation to the humerus, this can be brought on with a tight cast or significant pressure for a long period of time around the upper arm, bad intramuscular injections in the deltoid. If you miss the deltoid, go too deep and hit the radial nerve, you can damage the nerve. Generally quite localized. Breaks of the humerus can affect it as well. A lot of these situations will be breaks of the bones that damage the nerves. We'll see more of that coming up. Median nerve, anterior forearm damage, inability to flex the wrist, pronate the forearm, and also because there's a little bit of hand grip innervation there, the thumb muscles are weak specifically in this situation. Anterior forearm, you can't pronate, and the thumb muscles are quite weak. So anterior forearm damage, the median nerve. Ulnar nerve, this can be damaged anywhere along the medial border down near the distal portion of the arm or the proximal portion as it extends all the way up. We had that numbness in the medial 2 digits of the hand, and because most of the hand innervation arises from the ulnar nerve, the claw hand is a characteristic symptom or phenotype, I guess, of ulnar nerve damage. Now, I brought up, when we talked about the brachial plexus, the long thoracic nerve, specifically for this reason. So you can see it arising here, and it doesn't follow the rest of the nerves into the upper limb. It stays in the trunk. It stays in the trunk. It's this really small division under the red circle that extends down and innervates the serratus muscles. The serratus muscles, the ones on the abdomen that when you get them well defined, they look like a saw blade. I can't show you, I don't have them. The serratus muscles, and their job is to anchor the shoulder blade to the body. And so if the long thoracic nerve is damaged, you lose that ability to anchor the shoulder blade to the body. It's not anchored properly and can easily disengage. As shown down here, winging of the right scapula. So the right scapula over on this side, with hands up pushing against the wall, doesn't stay flush against the back, against the torso. It pushes out because the serratus muscles aren't active because the long thoracic nerve has been damaged. So the right scapula pushes out, it's coming out of the screen towards you. And there's some other issues with stability. You can't lift your arm past horizontal because you need that stable base of support of the scapula against the thorax to do so. Those are all individual injuries. The entire brachial plexus can be injured together. It can be compressed. There's compartment syndrome or compression syndrome. I often feel it when I dislocate my shoulder and then the humerus sits in this region with all the tangled nerves right there. Every dislocation I've had has been anterior and inferior. So the ball comes out of the screen and down and sits right about here, right on top of the medial cord, which is painful. It's not fun. It's not fun at all. One of my least favorite memories is after I went to the hospital. I can do it now. My shoulders are loose enough I can put them back in on my own now, but once I was in the hospital and they got me to lie on my front and have my arm dangle while it was dislocated, and the pins and needles sensation that you get when your nerves are stretched beyond what they're supposed to, and then you attempt to stretch them more, I wouldn't wish that on anyone. So rotator cuff exercises, really important. You guys do those already. If you were in fitness assessment and exercise prescription, it's a 4th year class that I've taught for the past few years. I tell a pretty embarrassing story of how that imbalance arose and why my shoulders are so weak. But I'm not going to get into that now. No time for fun and games in anatomy and physiology. Instead, we're moving on to the lumbar plexus. Luckily, not as much detail as the brachial plexus, only a few key characteristics to note here. Lumbar plexus has far fewer convergences and then divisions. There's much less of a network. There's few interconnections. The roots themselves split into anterior and posterior segments, and this happens just above the pelvis You can see it on the inset over here on the left, just above the pelvis. And really the only thing that I want you to notice, the main nerve arising from the lumbar plexus is the femoral nerve, or femoral nerve, depending on how you want to pronounce it. It's the major nerve that innervates the quadriceps and the knee extensors. Skin on the anterior surface of the thigh, femoral nerve. Arises here and travels down. We'll see that coming up. And that's literally it. That's all I want to talk about in this section. Size of relief all around, right? Femoral nerve is one of those ones that you're always concerned about when you take a muscle biopsy. Luckily, it's pretty deep, so you're not ever going to nick it or take a chunk out of it. I've had 32 muscle biopsies in my academic career. Now my legs are just scar tissue. But I remember having to go through the rigmarole of talking about where the femoral nerve is and making sure that you don't chop it when you do a muscle biopsy. Sacral plexus, last of the four. Cervical, brachial, lumbar, sacral. Immediately inferior to the lumbar plexus, hard to discern between the two a lot of the time. This one generally sits in the pelvic bowl. It's anterior to the sacrum, which is the back wall of the pelvis. You can again see the vertebrae over on the right-hand side. Notice the sacrum is just one large bone. It's individual vertebrae that are fused together. And so I've drawn it here as one large surface. Sacral plexus, home to the largest nerve in the body. Largest nerve in the body. That nerve is the sciatic nerve, which is fairly obvious if you're looking at the slide. Sciatic nerve is not one nerve though. It's two nerves joined together by a wrapping of connective tissue. They do split apart again eventually, just above the level of the knee. And if you were to guess what nerves they split into, it'd be fairly obvious looking at this picture without even knowing what the nerves are. They split into the tibial and the common fibular branches. Wow. The tibial and the common fibular are the two components of the sciatic nerve. And they divide later, just superior to the knee. So sacral plexus innervates the perineum, lower leg, buttocks, skin surface, and all those sensitive areas. Most innervation from the sacral plexus. Sacral nerve often related to a condition called sciatica. It's the whole reason why people tell you not to sit on your wallet on one side, because it compresses the sciatic nerve, and then you get this radiating tingle all the way down the back side of your leg and the top side of your foot, and it starts to affect how your foot moves. Specifically, the common fibular is what innervates that lateral side of the leg and the top side of the foot, and it's related to a condition called foot drop. Anyone heard of foot drop before? If you were to guess what, yeah, heard of it? Okay. If you were to guess what foot drop was, it's in the name. You can't dorsiflex the ankle. You can't lift your foot. Your foot hangs. And a lot of the reason for that is the common fibular nerve winds around the outside of the leg at the fibula. So, you know, there's two bones in the lower leg, and one of the small ones is just on the outside here, and it's prone to breaks. If you're going in for slide tackles playing soccer, or someone kicks you in the lower leg for some reason, that's the one that's going to break first. And the common fibula wraps right around the surface, so if it breaks, it's prone to damage. It innervates the muscles on the back side of the foot and the skin on the outside of the leg. Not only do breaks cause foot drop, but if you are a yoga practitioner and you do improper yoga, and what I mean by improper yoga is typically really deep knee flexing. So if you sit on your feet and your lower legs and lean backwards, and you really give one a one of these knee flexions, but you're really forcing and torquing the knee, just that pressure can injure the common fibular nerve. And so a lot of people that are extreme yoga goers might exhibit some foot drop symptoms as well from improper form. Not something to aspire to. So some common points about the sacral plexus. As far as the anatomy is concerned, we'll leave it there for now and turn our attention to the physiology, which, again, a lot of familiar faces here. A lot of familiar faces. It's no surprise. We've already talked about the two main roles of the spinal column. Two main roles. If I hadn't put this up, you could guess what they are. Integrate information, propagate impulses. Focus of the lab this week is to execute some basic reflexes, which is the integration aspect. And propagate is what we've always talked about the spinal cord as being, the highway, connecting point between the brain and the rest of the body. Of course, those roles are based on the devoted tissues within the spinal cord, white matter being the tracts within that convey information and propagate those signals. Gray matter being the area where we can integrate some information, where small, easy decisions can be made, where reactions can be processed, and we'll talk about a few of those today. So some small basic reflexes can be processed in the spinal cord. And the idea of processing, we often think about thinking hard. Processing information is thinking about it and coming to a conclusion. Processing can be that at the higher level and more complex level. But processing can be simply one direct response to some sensation. And you'll have seen that in lab this week if you've gone yesterday, or you'll see it if you go today or later on. There is such thing as single or multiple neuronal processing, monosynaptic processing. Let's take a look at the tracks just quickly. We've already identified the shape and distribution of white matter and gray matter within the spinal cord. And now we're going to look at a bit more detail about the roles in each area. So we have another section, a transverse section across the spinal cord. We can see the characteristic gray matter and white matter. We can tell where we're oriented. We know the anterior fissure points towards the front, anterior median fissure. The ganglia are part of the roots of the dorsum, or the back, the posterior aspect of the spinal cord, and it's labeled. So we are oriented really well. Now these individual tracks are generally named according to the terminals, or the termini, the points between which they convey information. And the order gives an idea of the direction of that information. Sometimes you'll also have information about their position in the spinal cord, but I'm not confident to say that's always going to be the case. And I'll show you a couple examples. So lateral corticospinal tract. Lateral corticospinal tract. Let's forget lateral just for a second. I'll come back to that because that's the spotty one. Corticospinal tract. Conveys information between the cortex and the spine. Cortex and the spine. Corticospinal. The arrangement of those two portions of the words indicate the direction. From the cortex to the spine. What kind of information goes from the cortex to the spine? Yeah? Motor? Efferent information. Efferent and motor, same thing. Absolutely. They're also coded red, which keeps up with our scheme that we've been using throughout. Motor is red. From the cortex to the spine, must be motor. And lateral implies that it's in the lateral column of the spinal cord. And it's nice that it works out here. It does for most motor tracts. Similarly, anterior corticospinal tract, from the cortex to the spine in the anterior column. We'll come back to naming when we get to the other, the complementary section. So these are examples of motor pathways, descending information to execute a task. These can either be direct or indirect. Direct or indirect. What I mean by direct or indirect is they are somatic or they're involuntary. You have conscious control over them or you don't. And these two are direct. These are the two tracts that convey somatic information from the cortex to the periphery. Conscious information to execute a task. The rest are involuntary. The rest are indirect. So direct is voluntary, indirect is involuntary. Direct is also known as pyramidal, because it goes through the pyramids of the medulla. Indirect or involuntary are extra-pyramidal. They don't go through the pyramids. So we have voluntary control over these movements. I can lift my arm and point. The other actions are automatically maintaining balance, something you've seen in lab or will see this week. On the other end of the spectrum, the sensory information, again, the name implies the terminals and the direction. Let's maybe take a look at this one's not as nice. How about the posterior spinocerebellar tract? Let's think about that for a second. Spinocerebellar tract. Information goes from the spine to the cerebrum. Is that right? I see some head shakes, and you'd be correct to shake your head. Not the cerebrum. Cerebellum. I was looking to see if I could tell a difference between your bored copying notes face and then the hold on, the discerning face. Something's amiss. Couldn't tell. Which I don't know if that's good. Cerebellum, spine to the cerebellum. In that direction, in that order. Unfortunately, we don't have a nice indication here of where it is within the spine. The posterior is half right. It's in the posterior half of the lateral column. So the location doesn't work as well for the afferent tracts. And certainly when we get to the posterior column, which I have highlighted here, there's not even an indication of the two terminals. But the posterior column is the only column that conveys somatic sensory information, the information you are aware of. Conscious sensations, vibration, itch, tickle, etc. Posterior column. And we don't necessarily care that it's the gracile fasciculus or the cuneate fasciculus. Don't need to know those names, but the posterior column is what's important. Somatic sensory information. Everything else, involuntary, not somatic. Three minutes, is that enough to even get into reflexes? You're wrong. I heard you say no, but it's time. We're going to look at one slide. We're going to look at one slide and you get a lot of this detail in lab anyways. Some of this is just repetition from what you've heard in lab, those of you that went on Monday. And a bit of extrapolation. There's not too many slides left, but reflexes are what you test, a large part of your lab activities this week. And when we say reflex, I'm thinking a fast, involuntary response. The tendon tap with the knee. Some of you have done that already this week. There are voluntary and involuntary reflexes. There are different levels of reflexes. If the reflex occurs in the spinal column, it's a spinal reflex. If the signal travels to the brain for processing and an efferent is returned, it's a cranial reflex. And some reflexes we are aware of and can control. Others are autonomic. Blood pressure is a reflex that's autonomic, that we don't control. Equilibrium and balance is a fairly complicated reflex that we don't control. Generally, somatic reflexes are those that innervate skeletal muscle. Autonomic innervate other things. Glands, cardiac muscle, smooth muscle, adipose, not skeletal muscle. Somatic, skeletal, autonomic, everything else. And there's a lot more detail about the diversion and explanations of cranial versus spinal in lab. You test those two in lab this week. We'll go through the flow chart for a basic reflex when we come back to class on Thursday. It'll be old news by then. You'll be very bored. But we're going to look at some new reflexes as well that you didn't test that allow us to move our limbs, lift weights, etc. So have a wonderful Tuesday. See you Thursday morning.